Hello, my dear viewers, and another episode of Outpatient Clinic. This episode is titled Causes of Back Pain. A lot of you guys have had back pains at least once or twice in your lifespan, and some people have chronic back pain almost daily, so it's a very important topic. So what are the causes of acute or chronic back pain? This could be due to trauma or heavy labor or heavy lifting or repetitive bending and twisting, poor general health, smoking, drugs, a tumor in the back, infection in the back, sciatica, or herniated disc is a big one affecting a lot of people in the United States. And it's going to cause severe pain and can cause nerve damage. So it's very crucial we diagnose and treat. Red flags such as neurological deficit, age above 50, marked trauma or car accident, drug abuse, history of cancer, whether you have prostate cancer, lung cancer, can spread, it can go metastasis to the back, certainly cause a lot of pain. Continuous pain for more than a month is the red flag. Prolonged cortisone abuse, people with chronic asthma and chronic steroid use, people that are taking steroids for whatever reason, or you do have systemic disease such as systemic lupus, erythematosus, taking prednisone 5 or 10 a day, then with time can get osteoporosis, can get fracture in the bones in the back, can get back pain. Some rheumatological diseases can cause that as well. So we do take a good history, we do an exam, we look for any neurological symptoms or signs on your exam. We tell you to change your work habits and certainly have no heavy weight lifting. We ask you to stop drugs. We ask for a history of any of drug abuse or smoking. We ask for previous back pain or cancer or previous herniated disc. And big one, we ask about incontinence to urine and stools. And why is that? Because if you have sciatica or you have damage to the lower lumbar spine, it can cause incontinence to urine and incontinence to stools. So this is dangerous and can be needing surgical intervention. We do ask about erectile dysfunction from injury to the back. So certainly we have to take a thorough history and a thorough exam. On the examination, we look for spine tenderness, we look for the range of motion, we look at the motor power strength, your muscles of the thigh, muscles of the back, whether or not you start to have weakness in the muscle. If the problem is cervical spine, we look at the shoulder muscles. In the thoracic spine, we look at the weakness. If you have damage of thoracic spine from a trauma or car accident, we look also for weakness in the muscles of the thigh. We look at the sensation, whether or not you're having less sensation or tingling or numbness or any indication that you have a nerve damage. And finally, we do something called straight leg raising. You're sleeping in the bed of the examination bed in front of in your doctor in the clinic, and he asks you to start straight leg raising. And if you get back pain, certainly that's indication you have a problem in your back. So we do some lab tests such as erythrocyte sedimentation rate, which could be increased with any inflammation. We look at the PSA, prostate specific antigen, for people with prostate cancer. We look at serum or urine protein electrophoresis. This can be high in people with something called multiple myeloma, is a disease of the blood that can affect the bones as well. We look at rheumatoid factor, a test called anti-nuclear antibodies, especially in women, a test called B27, and anti-double-stranded DNA if we suspect lupus. We started with an X-ray of the spine to look at the whole spine, see if there's any degeneration. Next, we can do a CAT scan of the lumbar spine, but we can also do a MRI of the spine. I like the MRI a lot because it can tell us if there's herniated disc or a spinal stenosis or any cancer or abscess. CAT scan may miss some of those, but the MRI is more sensitive. The bone scan is done in certain cases in multiple myeloma or suspicious of metastatic disease, different areas of the body with the lung cancer, prostate cancer and really look at the bone survey, the whole bones. Some cases of breast cancer or other types of cancer, we do PET scan, and certainly you can see the bones as well. The treatment, rest can help in a lot of cases. We can use ice packs or heat in acute trauma to the back. We advise for proper activities. We advise for a proper mattress. Some pain medication might be used, such as Tylenol. Non-steroidal anti-inflammatory drugs, we advise you take under the supervision for a physician, like Motrin, Aleve, Naproxen. These can cause ulceration of the stomach, can cause you to have a gastrointestinal bleeding, can cause worsening of renal function, kidney function. So you have to be careful. Do not abuse this medication. Muscle relaxants such as Somaflexeril, Tizanidine. We do use Tramadol or Norco in severe cases. We do send patients referral to physical therapy and epidural injection. Now, bear in mind this just for your information and education. Please do not take this video as a treatment. This is not meant for a treatment of anybody. I'm not your family doctor. However, you must have a family doctor, primary care doctor. This is more education for any couples at home that would like to see my videos and learn something from it or bring some questions to their physician. So please do not take this as medical treatment or medical advice over the internet. Rather, I'm just explaining for informational purposes only. Surgical treatment can be done by laminectomy. Laminectomy, you remove the lamina, which is the part in the back of vertebrae, to relieve the pressure on the nerves. We can do fusion surgery. We can fuse 2 or 3 vertebral bodies, such as L1, 2, 3, or sometimes L1 through 5. We can do discectomy, remove the disc. Sometimes we put artificial disc in its place. We can do 2 surgeries of these, such as laminectomy and fusion together, or discectomy and fusion. Surgery, you need spine surgeon, experienced one, to look at you, look at the MRIs, examine you, and provide the appropriate surgery. We don't rush to do surgery right away. Surgery is the last resort. And we do take care of urgent matter, something with cord compression. Car accident with cord compression need emergent surgical treatment if needed. Otherwise, your patient can end up with paraplegia or quadriplegia. People with metastatic disease, we need to see them in the ER with a severe back pain, especially if they have start weakness on the lower thigh, or if they're wiggling their toes, I need to start treatment. The treatment is cortisone in the ER, something called Decadron shots. We give 10 milligram intravenous in the ER, then every 6 hours we give 4 milligram and do the MRI, call the surgeon to assess whether or not you need surgical treatment. The caution, if you delay the treatment of cord compression, is too late. The spinal cord is very sensitive, 6 hours, 12 hours, 24 hours, then you get paralyzed. So you need to relieve the obstruction. The Decadron is life-saving, decrease pressure and decrease inflammation around the spinal cord until certain modality or surgical treatment is done. This is a slide of somebody showing severe back pain on both sides of lower back. This is normal disc. The second one is degenerative disc. As you can see, this is getting worse and more thinner. And this one is disc bulging. When you bulge here, the nerves are exiting here. So you get L4, L5, L3, whatever nerve, and you're pushing on it, it gets one side of the body severe intractable back pain. And the nerve can be pushed dramatically, can cause tingling or numbness or weakness of the muscles of the thigh, and then you get motor weakness, almost paresis or even paralysis. So you need to see your doctor right away and do MRI right away and see what treatment you need. This is another herniated disc with complete bulge and more pressure and severe pain. This is a slide of a thinning. The disc is thin. So in that case, it's very thin. Compare this one to that one, there's quite a difference. This one is disc degeneration with osteophyte, some bone formation here, extra bone. Certainly these can cause severe pain. This is another slide of a normal disc, degenerative disc disease, bulging disc, severe bulging and herniation to the point of crushing the nerve, causing severe pain, and paresis or weakness. This is the thinning of the disc. This is a disc degeneration with some extra bony formation. This is an MRI showing you the disc bulge and it affecting the spinal cord right here. This is the normal disc. This is the herniated disc. This part is herniated. This is the vertebrae. This is the lamina, the backbone. It kind of like a triangle here. And this is the disc. This is the cushion, if you will. This disc has two parts. The core part, the heart of it, is called nucleus pulposus, and the periphery or the ring of it is called disc annulus. When the disc is disrupted, the nucleus pulposus, this part gets mushy and kind of push, and the disc rupture or bulge through here. And you can see it's pushing on some nerve. The yellow part is a nerve and causing severe crushing or pain, or bulging to the point is affecting the nerve, causing pain. It tells you in the MRI here, this is the disc and it's bulging, and you can see this is the normal spinal cord. Here it gets pushed around and causing severe, almost cord compression here, and needs to be dealt with. This is a treatment called epidural injection. It can be given every 3 months. Your doctor under fluoroscopy, under certain machines in a special procedure room, usually outpatient. Sometimes you do it interventional radiology inpatient. You go with a needle, it goes to the epidural space. You do not inject the spinal cord. You don't go to the yellow part. It's in spinal cord. You can cause damage, paralysis. You go on the epidural space, this kind of black space. You go in there, epidural space, and you inject the cortisone, decrease the pain, decrease the inflammation, give you a relief for 3 months. During those 3 months, you can refer your physical therapy, hoping the herniated disc will get back to where it's supposed to be. This is how the doctor performed this. Special spine surgeon or interventional radiologist can do that. This is the lamina, and we did laminectomy. We broke this part, we removed it, and we relieved the compression, we relieved the compression on the nerves, we relieved the pain. This could be just a simple laminectomy. Sometimes they do laminectomy and discectomy. They remove this disc and put artificial disc, or sometimes they do laminectomy and fusion surgery. Like this. You see there's nails, screws, and nailing, and you kind of do fusion between all these 3 lumbar vertebrae. This one, you have fusion between L3, L4, L5, and S1. So you kind of got all these 4 levels. You do fusion to stabilize, decrease the pain. A lot of times you remove the disc and just put the fusion. And this is a big surgery, and the decision of surgery is done by your back surgeon, spine surgeon, only after reviewing your MRI, especially if other modalities, including epidural injection, has failed and you have severe disc bulge and you have severe symptoms or paralysis or paresis. This is again, it shows you kind of the nice slide where you have the nailing and the screws, and you did fusion between these 2 vertebrae, and in this case you kept the laminas, so you did not do laminectomy. Dear viewers, I hope you have learned something from this video. I really appreciate your time. Please feel free to email me. I will put my email address on the bottom if you have any question. But again, these videos are just for information, educational purpose. It does not constitute any treatment over the YouTube channel at all. Please refer to your family physician or appropriate treating physician or your primary care physician and talk to him and ask him questions. Hope that this video at least helped you what question to ask and what information to guide you, but you should see your family physician right away. Again, I was pleased to show this video. I hope you learned something from it. I will see you in the next video. Thank you so much for watching.